Is this one better?
Yes, much better. Thank you.
This slide shows one of the new ways that CDC is visualizing the impact of COVID vaccination on the COVID data tracker website. The graphs display weekly trends by age group for the cumulative percent of people fully vaccinated in blue and the average rate of new cases per 100,000 population in gray. The three graphs at the bottom in the red box represent the three age groups greater than 50 years of age. Here we observe higher coverage rates and lower case rates compared with the younger age groups shown above that have lower coverage and recent increases in cases. Next slide. This map, also from COVID Data Tracker, shows a county-level view of the case rates per 100,000 population over the past 7 days compared with vaccination coverage rates. A legend is shown on the right. The magenta and purple colors that predominate the map are counties with low vaccination coverage and high recent COVID incidence. The green and light blue colors are counties with higher coverage and low COVID incidence. Counties colored navy blue, which represents greater than 50% coverage and high incidence, are relatively few and reflect the recent increases in Delta variant transmission occurring largely among unvaccinated persons. Next slide. A lot of public concern has been raised on the Delta variant and breakthrough transmission, which I'd like to try and contextualize with two example state scenarios, each with 1 million population and different coverage levels. State A has 70% coverage on the left, and State B has 30% coverage on the right. The COVID data used for this example are actual data from the COVID Data Tracker website for states with similar coverage levels. The dots each represent 10 COVID cases, and in State A, 130 cases are occurring per week, compared with over 5,000 cases occurring weekly in State B. Using the vaccine efficacy estimates from the UK, we can estimate the number and proportion of vaccinated cases shown in red and vaccinated cases shown in blue. Proportionally, there are more vaccinated cases in State A at 22% of cases vaccinated, compared with just 5% in State B. But this is expected because the proportion of cases vaccinated increases with increasing vaccination coverage. At the extreme of 100% vaccination coverage, all cases would be vaccinated because no vaccine is 100% effective. Next slide. Similar trends with hospitalization are observed below, where 1 dot equals 1 hospitalization. In State A, just 1.4 hospitalizations occur weekly, and in State B, 18.8 hospitalizations occur. In both states, the majority of cases and hospitalizations are among unvaccinated people. Next slide. Next slide. 4 variants are considered variants of concern. Alpha or B117 first detected in the UK, Beta or B1351 first detected in South Africa, Gamma or P1 first detected in Brazil and Japan, and finally Delta or B1617.2 first detected in India. Attributes of the variants related to public health impact are noted in the table. Of note, all of the variants of concern have mutations in the receptor binding domain that have variably impacted vaccine efficacy, with the cluster of mutations shared by Beta and Gamma having the largest known impact. Another class of variants under monitoring are the variants of interest, which have similar mutations but less current evidence of public health impact. Next slide. These are our latest national nowcast projections of the proportions of circulating SARS-CoV-2 variants from CDC's COVID Data Tracker. The stacked bars show the observed historic estimates and the most recent nowcast projections for the commonly sequenced SARS-CoV-2 lineages in the U.S. by 2-week interval specimen collection date. The variants of concern depicted in different orange shades have increased over time. In projections for the 2 weeks ending July 31st, Alpha decreased to a projected prevalence of 2%. Gamma decreased to 1%, and Beta remained at 0%, while the Delta variant increased to 94%. Recently, the graph was changed to display the different delta sublineages, and AY3 has increased to 13%. This sublineage does not contain the so-called delta plus mutation. Next slide. We have several types of evidence that we monitor to assess the impact of variants on vaccines, including antibody neutralization generated in the laboratory. Though we note that a correlate of protection is not yet established, good correlation has been observed between vaccine efficacy and the neutralizing antibody levels from different vaccines, and this will likely be the first type of evidence we get on the impact of new variants on vaccines. We also monitor vaccine efficacy data from clinical trials and real-world vaccine effectiveness studies. We note that a greater proportion is usually observed against severe disease, or greater protection is usually observed against severe disease than symptomatic illness, and confirmed infection, which includes asymptomatic cases. And this is because protection against severe disease requires lower antibody levels and is less affected by differences in efficacy across vaccines. Finally, we monitor vaccine breakthrough infection, and I'm going to review these types of evidence now. Next slide. We conduct a review of available studies on vaccines authorized or intending to be authorized in the U.S. and containing data on the ability of post-vaccination sera to neutralize SARS-CoV-2 variants. In this dot plot, the reduction in neutralization of the variants is shown relative to the wild type or dominant strain used in each study, where no effect equals 1 at the bottom of the y-axis. Each dot represents one study result, with mRNA results shown together in blue, AstraZeneca in yellow, Novavax in brown, and Janssen in green. Beta had the largest median reduction at 7.5-fold, Delta had a median reduction of 2.8-fold, Gamma was reduced 3.1-fold, and Alpha was reduced 1.9-fold. While an Alpha variant with an E484K change, which has been detected in the UK, US, and other countries, had a further reduction in neutralization compared to Alpha alone. Next slide. In terms of what is known about duration of immunity, to date, available data demonstrate antibody persistence for at least 8 months after COVID infection and at least 6 months after the second mRNA vaccine dose, with some evidence at 8 months for the Janssen vaccine. Studies suggest individuals may maintain long-term protection from severe illness caused by antigenically similar strains, even if they become susceptible to mild infection. 2 studies have shown a combined impact of waning antibody levels and reduced neutralization of variants. At 6 months after receiving the Moderna vaccine, neutralizing antibody levels were reduced but sufficient to protect against the ancestral strain, while about 50% of people had undetectable neutralizing titers against the Beta and Gamma variants. A small study at 8 months after receipt of the Janssen vaccine observed minimal decline in neutralizing titers and improved protection against Beta, Gamma, and Delta variants, compared with 1 month after vaccination, which was suggested to be related to antibody maturation. It's unclear if there are differences in the kinetics of antibody response by vaccine platform, and more data is needed. Next slide. Pfizer recently published their 6-month clinical efficacy data. Vaccine efficacy, or VE, against infection out to 6 months was 91%. They performed an additional analysis looking at different time intervals after receiving the second vaccine dose and observed a gradual decline in VE against infection of 6 percentage points every 2 months, though the confidence intervals around the estimates were overlapping. At 4 to 6 months post-vaccination, VE was 84% compared with 96% at less than 2 months after vaccination. VE against severe illness during the period was 97%. Moderna has not yet published their extended efficacy results, but announced in a press release that VE was 93% for up to 6 months. Next slide. In terms of VE against the variants, for the Alpha variant, mRNA vaccines have been shown to have greater than 85% real-world VE against confirmed infection in the US and multiple countries. For Gamma, mRNA vaccines had 84% to 88% real-world VE against symptomatic infection and 79% VE against confirmed infection when Gamma was widely circulating in Canada. For Beta, Moderna vaccine had 96% real-world VE, and Pfizer vaccine had 75% VE against confirmed infection in a study from Qatar, while Janssen vaccine had 52% VE against moderate or severe disease in their clinical trial in South Africa. Importantly, all studies observed high VE against severe disease. Next slide. In terms of what we know about the Delta variant, it's nearly twice as contagious as previous variants. There is some evidence of increased illness severity compared with previous strains in unvaccinated persons. The greatest risk of transmission is still among unvaccinated people, and fully vaccinated people with Delta breakthrough infections can spread virus to others. However, when vaccinated people with Delta may be infectious for shorter periods than unvaccinated persons with Delta. Next slide. For the Delta variant, vaccine effectiveness studies have been published from several countries, mostly for the Pfizer vaccine. In England and Scotland, reduced Pfizer VE was observed at 79% for infection and 88% for illness compared to 92 and 93% for the Alpha variant. Protection against hospitalization from Delta was 96%, which was similar to that observed with Alpha. In Canada, Delta VE estimates were similar to the UK, but with smaller differences in VE for Alpha and Delta. Israel has observed a progressive decline in VE during the period after Delta predominance, with the most recent VE estimates of around 40% against infection and illness, while VE against severe disease has remained above 90%. Qatar was the only country that assessed Delta VE for both Pfizer and Moderna, shown with hollow symbols. VE against symptomatic illness was 54% for Pfizer, compared with 85% for the Moderna vaccine, while VEs against severe illness were above 90% for both. It's important to note that the comparisons shown for the Alpha and Delta VE in Israel and Qatar are for different studies that were separated by 2 to 5 months during the time periods when Alpha and Delta circulated. Other methodologic differences may explain some of the variation observed in the study results across countries. Next slide. Other potential differences in VE results relate to differences in the vaccine programs by country. In the US, we use the Pfizer, Moderna, and Janssen vaccines, which have followed the manufacturer-recommended intervals of 3 and 4 weeks between mRNA doses. Israel has also used Pfizer vaccine, and has only used Pfizer vaccine, though they also authorized Moderna, and followed the 3-week interval between doses. Israel also had a very tight cohort with more than 50% of the country vaccinated in the first 3 to 4 months. Qatar is the most similar country to the US in terms of using both Moderna and Pfizer at the same dosing intervals. Finally, the UK and Canada are the most similar to each other in that they both use mRNA and the AstraZeneca vaccines. As part of a dose-sparing strategy, they also adopted extended dose intervals of up to 12 to 16 weeks, which were later shown to improve immunogenicity and VE compared with standard intervals, including for ages greater than 80 years. The countries also support mixing and matching between vaccines, which has been shown to increase VE. I'll also note that the Pfizer vaccine has a lower mRNA dosage, an accelerated schedule of 3 weeks compared to 4 weeks for Moderna, which has the potential to impact the robustness and duration of immunity, as has been generally observed for other vaccines. Next slide. In public data from Israel, the Ministry of Health has observed higher breakthrough rates and lower Pfizer VE against infection for persons vaccinated during January to February than in more recent months for persons aged 16 to 59 and 60 years and older. 2 retrospective cohort studies of persons vaccinated with Pfizer in large healthcare systems observed increasing breakthrough infections among persons vaccinated in January versus April, and higher breakthrough infection rates among those who received the second mRNA dose more than 5 months ago compared with less than 5 months ago. All age groups were impacted, but one study observed higher magnitude of differences with increasing age. Next slide. Delta only rose to predominance in the US at the end of June. This week, the first study assessing potential VE changes in July was posted from the Mayo Clinic healthcare system. For patients in Minnesota, the authors observed that VE against infection was significantly lower for both Moderna and Pfizer vaccines in July, when Delta variant was more than 70% prevalent compared with previous months, and significantly lower for Pfizer at 42% compared with Moderna at 76%. Importantly, the effectiveness of both vaccines against COVID-associated hospitalization remained consistently high during the same time frame. More information is needed in this area and will be forthcoming. Next slide. Despite high efficacy, vaccine breakthrough cases are still expected to occur, including those caused by circulating variants. CDC conducts nationwide monitoring of vaccine breakthrough cases resulting in hospitalization or death. As of August 2nd, among more than 164 million fully vaccinated in the U.S., there have been 7,101 hospitalizations and 1,507 deaths with vaccine breakthrough reported to passive surveillance. Among hospitalized or fatal breakthrough cases, 75% were 65 years or older. In addition to national passive surveillance, CDC has a number of other ways to monitor breakthrough infection, including a population-based surveillance system called COVIDNet, which represents 10% of the U.S. population. The most recent COVIDNet data on COVID-associated hospitalizations among adults estimated 32% of all vaccinated cases are immunocompromised versus 11% of unvaccinated cases. Next slide. To summarize, alpha, beta, and gamma variant have low prevalence in the U.S. Alpha has minimal impact on VE, while beta and gamma have moderate impact, though the vaccines appear likely to protect against severe disease. Delta has high prevalence in the U.S. and has moderate impact on vaccine effectiveness, though the vaccines are likely to still provide protection against severe disease. More data is still needed on the impact of Delta, especially for the Janssen vaccine and the potential for waning immunity. Next slide. Manufacturers are conducting booster studies of current vaccines and or second-generation vaccines against the beta variant. Moderna has posted preliminary results of a phase 2 trial of a single booster dose of the previously authorized and a beta variant-specific vaccine. Both vaccines had acceptable safety and boosted immunity to the wild-type strain as well as to the beta and gamma variants. Pfizer has also submitted preliminary data on a booster of their original vaccine to the FDA. No Delta-specific booster vaccines have been shared to date, or studies have been shared to date. In summary, next slide. In summary, the currently authorized vaccines work against known variants. Given the increased risks related to the Delta variant, it is important to increase vaccine uptake in all eligible populations. CDC is closely monitoring real-world vaccine effectiveness and breakthrough infections using multiple methods, populations, and outcomes. CDC continues to monitor emerging variants, including their prevalence and impact on disease incidence, severity, and vaccine breakthrough. The ACIP will review evidence submitted for boosters and any next-generation vaccines to address the evidence of diminished VE related to the variants or waning immunity. Finally, this is a changing landscape, and CDC will continue to communicate promptly about emerging evidence. Thank you.
Thank you, Dr. Scobie. And this presentation is now open for questions. Ms. Bata.